Alright, in this lecture we're going to look at anti-seizure drugs, or drugs used to treat seizure disorders like epilepsy. And we'll see that drug therapy is certainly the most common way to treat these conditions. There are some surgical procedures, some other electrophysiological interventions that can be used in specific situations, but by far the most common way we're going to see our patients have their seizure disorders controlled is using medications. So we're going to explore these medications. First, we'll talk a little bit more about the seizures themselves. So what is the seizure? It's a recurrent, uncontrolled cerebral excitation. In many situations, a group of neurons start the seizure activity or initiate the seizure activity. That activity can then remain localized in one area of the brain, or it can spread throughout other areas of the brain, depending on the type of seizure. Regarding seizure disorders, the cause is often unknown in younger people. Granted, a child might have cerebral palsy or some other cerebral insult, but it's not like we have a very distinct episode that caused the seizure to begin. In older adults, there may in fact be a specific event or episode, like a stroke, a cerebral vascular accident, a tumor, head trauma, or closed head injury, and so forth, or metabolic imbalances. But as I said, the majority of seizures is no one distinct episode that initiated the seizure. And we do classify seizures according to various factors like the extent of the brain that's involved, or cerebral involvement, the EEG activity that occurs during the seizure, the symptoms that we can observe in a patient, and so forth. And of these classes, we have two primary subdivisions. First are called focal or partial seizures, and there you have subclassifications of that, such as simple focal seizures, complex focal seizures, depending on the patient's symptoms, as opposed to the more generalized seizures, such as the absence seizures, what we used to call petit mal seizures, the tonic-clonic seizures, what we used to call grand mal seizures, and various other generalized seizures. A third category exists to classify any seizures that don't fit into the first two categories. So by understanding these classes, we can better get an idea of what drugs might be the most useful in various types of seizure disorders. In terms of seizure type, this just gives you a sense that they're not all equal. The most common are the complex partial seizures, with the generalized tonic-clonic, or the old, what we used to call the grand mal seizures, being second, and then various other seizure disorders or types of seizures constituting other percentages, as you see on this pie chart. So we do have, again, it's not an equal tendency for different patients to have different types of seizures, that it is relative. The prevalence of different types of seizures does certainly vary. Which leads us to the anti-seizure medications. The goal here is selective effect on the neurons that start the seizure, or the so-called hyperexcitable neurons, which makes sense. If you can keep these neurons from initiating the seizure, it won't occur. We'll see that it's not hard to do this. It's not hard to control these hyperexcitable neurons. The trick is to be selective. So selective, or selectivity, is the key term in this goal. If we can keep the neurons that start the seizure under control, that's good. But we want to do that without impairing the function of all the other neurons, the normal neurons, throughout the brain. And that's a lot harder. So there are many categories and various agents in these categories, several dozen anti-seizure drugs. Of these drugs, we often see a few drugs that are sort of considered the first line or front line agents. So what we're going to do is start there and talk about these so-called frontline drugs. Doesn't mean they're always the first drug used, or that they're the only drugs that can be used, but it's a place to start, and it's a place to consider that these are often the first consideration. So let's take a look at these frontline drugs first. So in terms of the primary anti-seizure agents, Dilantin, phenytoin, or its trade name Dilantin, very common. Same with Tegretol, which is carbamazepine. Zerontin, again, fairly well known. The valproic acids like Depakine, divalproex, Depakote, and several other trade names. These are the front four. And as I said, they're not the only drugs used. They may not even be the first drug used, but oftentimes they are. So before we go any further, we should mention two other categories that are also very common. And they are the benzodiazepines and the barbiturates. And benzodiazepines we talked about briefly in the muscle relaxant. We see these used commonly in psychotropic conditions like anxiety. They help quiet the central nervous system. Likewise, barbiturates work very similar to the benzodiazepines. They increase the effects of inhibitory transmitters and keep the brain quiet. But clearly, they're not very selective. They're going to have a more general calming or quieting effect on neuronal activity throughout the brain, which takes away some of their selectivity. However, these are some of the most effective drugs, including especially the barbiturates. Phenobarbital, a barbiturate drug, is the most commonly used anti-seizure drug worldwide. It's very effective. It's very affordable, but it does not really have selectivity. And then we get into an issue of dosage, trying to find the dose that controls the seizure without causing a lot of generalized inhibition throughout the brain. So those are our primary drugs. Let's take a look at what else we might have as a possible intervention, pharmacological intervention for seizures. Now this is curious. We're going to talk now about what are called the second generation or newer generation anti-seizure drugs. For about 20 years, back in the late 20th century, from about 1980 to around the turn of the century, there really was not a big influx of new anti-seizure drugs to the market, which is curious because we always see new drugs coming onto the market for various conditions, but it just wasn't true. Then as we, I think, began to diagnose seizures better and learn more about seizure activity, there was this sudden upsurge of what we call these newer agents or second generation agents. For example, drugs like gabapentin, Neurontin, lamotrigine, Lamictal, and you'll recognize several of these trade names. Keppra, another one, Lyrica, very common trade name, Gabatril, and Topamax, and there are even a few others in this category. So these drugs all of a sudden started to come flying onto the market. And the obvious question was, so what? Are they improving our treatment of seizures? So let's focus on that for a second. Did these newer second generation drugs actually replace the more traditional drugs that we saw earlier? Let's talk about that on the next slide. So what are the benefits of the second generation or the newer drugs? They don't seem to necessarily be more effective than the traditional agents, but these newer drugs tend to have a milder side effect characteristic and be more predictable in terms of how they're absorbed, distributed, and eventually metabolized in the body. With the traditional drugs, there's a lot of variability from one patient to the other in these characteristics. They tend to have more side effects, more severe side effects, and they tend to have more differences from person to person in terms of how they are absorbed, distributed, and eventually metabolized. So what this did is, because of this, we tended to not combine the traditional drugs with one another too much. It was more likely that a patient would receive what's called monotherapy, a single drug, and they would use as high a dose as they could to treat the seizure as long as it was tolerated. But you didn't want to combine several traditional drugs together because it added to the complexity and it added to the chance of side effects. The newer drugs came along and allowed more drug combinations. In other words, we can still use one of the traditional drugs, but maybe at a lower dose, because we can supplement it with some of these newer drugs and add more of a cocktail effect to the treatment of the seizure. And as a result, we saw some patients, or many patients in fact, that did not get good control with a high dose of a traditional drug, now getting better control with one of the traditional drugs and one or more, maybe even two of these other newer drugs coming at the seizure from different angles. So this was a big help to a lot of patients who were not well controlled with a single traditional drug. The other benefit and the other reason we see these drugs a lot in rehabilitation is it was discovered they also may have benefits in neuropathic pain. Neurontin is certainly the most famous for this, but Lyrica, Keppra, Topamax, and pretty much all the other ones that are in this category, it was discovered accidentally that they may be helpful in chronic pain, things like diabetic neuropathy, fibromyalgia. They don't work differently. They have the same effect in chronic pain that they're having in seizures, and that is they quiet the neurons. But instead of quieting the neurons that start a seizure, they're quieting the neurons that are perpetuating and promoting the chronic pain syndrome. So this was a big breakthrough to a lot of our patients. And we're going to go back to focusing on the treatment of seizures in a second, but it really was important for a lot of people to now have this option of some of these anti-seizure drugs in treatment of various types of chronic pain, especially chronic neuropathic pain. And this was a major, major benefit. So we're talking back again about treatment of seizures. How do these drugs control seizures? And ideally, how are they somewhat selective for the neurons that start the seizure? We see that three of the big four drugs, Dilantin, Tegretol, Depakine, they work by inhibiting the entry of sodium into neurons that are firing too rapidly. We know that sodium channels have to open and close to generate action potentials. It's the opening of the sodium channel allows sodium to enter, and this is true for any neuron, and it's that entry of sodium that starts an action potential. In these seizure-initiating neurons, these channels are opening and closing faster than they should. So the drug is going to bind to that channel, and it's going to preferentially pick out the channels that are doing this, that are opening and closing too rapidly. What the drug then does is causes the channel to reset and go back to a more normal firing rate. So again, that's three of the big four right there. The fourth one works similarly, but it decreases the entry of calcium into thalamic neurons. Calcium is also excitatory. It's a divalent cation. It has two positive charges. So the entry of calcium is important in exciting certain neurons in the thalamus. And when these channels are overactive, we get these thalamic-related seizures. So Zerontin works that way. Very similar, but certainly in a different part of the brain and a slightly different electrolyte mechanism, calcium instead of sodium. Those are our four drugs right there that we said were really the kind of go-to drugs for a lot of patients with seizures. Now, several of the drugs, both traditional and newer, work by increasing GABA inhibition. GABA, again, very important inhibitory neurotransmitter. We're trying to get more inhibition in the brain to calm down neuronal activity. And the barbiturates, the benzodiazepines, and some of the newer drugs like gabapentin certainly work this way. And finally, some of the newer drugs work by decreasing the release or effects of excitatory transmitters, especially excitatory amino acids. We know now that certain amino acids act as true neurotransmitters in the central nervous system. And some of these amino acids, like glutamate and aspartate, are excitatory. Others are inhibitory, but it's the inhibition of the effects of these excitatory amino acids that allows us to have less excitation throughout the brain, and especially, hopefully, in the neurons that initiate the seizure. So we see this, again, array of different effects. And I think you get a sense now of why combining one of the traditional drugs that affects sodium might be helpful if we combine it with a different drug that affects GABA, and maybe even a third drug that affects amino acids. You're coming at the problem from different sides, from different angles. So some more justification for why some of these cocktails might be beneficial. This is summarized schematically on the next slide. Now, side effects. We say all drugs have side effects. What I've done is categorize the anti-seizure side effects into two types. First, the ones that are relatively minor, and by minor I don't mean that they're not important. I mean that oftentimes we try to find a dose that the patient can tolerate because the priority, of course, is to control the seizure. But these are not necessarily life-threatening. Sedation, very common with a lot of these drugs. As you try to quiet neuronal activity in the brain, some sedation is almost invariable. Headache may occur in some patients, especially initially at treatment. Dizziness likewise. Incoordination, as we start to suppress neuronal activity, they get some effects of incoordination. And of course, GI problems are very common, probably the most common problem with any kind of medication, and are certainly true here. Nausea, vomiting, some cramping, some diarrhea. More serious side effects, by this I mean oftentimes needing some intervention in terms of changing the medication or at least changing the dose, because these become very serious and maybe even life-threatening. We're talking about things like liver toxicity and decline in liver function, blood dyscrasias, which means a defect or a problem with the formed blood elements, red blood cell, white blood cell, and platelet formation. For instance, problems like aplastic anemia, formation of red blood cells, or lack of the proper number of white blood cells that leads to agranulocytosis. This can be very serious and it can be life-threatening. And finally, we know that these medications are associated with an increased risk of birth defects. Oftentimes, it's neural tube defects like spina bifida. And the general rule is that anti-seizure medications approximately double the risk of these types of birth defects. So we know this is true. It speaks to the idea that a mother who's expecting to have a child should be aware of these problems and discuss it with their partner and their physician. The one thing the mother should not do is independently decide to not take their anti-seizure meds, because that puts the mother at risk and therefore puts the baby or the fetus at even greater risk because of an uncontrolled seizure that could be serious or even fatal. So we know this is true, and we know we can control it to some extent by good prenatal care, making sure the mother is acting in a healthy fashion, eating properly, taking folic acid supplements to decrease the risk of these neural tube defects. But again, the only thing that the mother cannot do is independently or without other people knowing it, go off her anti-seizure meds, because there have been some very serious and tragic responses to that. So those are our major side effects.
Press pause and read the following question before proceeding to the next slide for the answer.
Now the question often arises, does a patient have to be on anti-seizure meds for their entire life? And some patients do, there's no question. But we do know that about 60 to 70% of patients that go off their meds can remain seizure-free once the medication is withdrawn. And this seems especially true if, and success is associated with, the patient being free of seizures for at least 2 years while on the medication. So what we're seeing is the medications were effective in controlling the seizure, possibly even letting the brain recover from the initial seizure activity. Second thing, having good seizure control initially within the first year after the seizures begin. By obviously being able to control the seizure initially gives us a better sense that the brain again can recover maybe. Having a normal neurological exam prior to withdrawal, and especially if the seizures began in childhood. This may have something to do again with the maturation of the nervous system. that as the nervous system matures, possibly the initiating factors of the seizure, as long as we can keep it under control with the medications, may have a chance to go off of these medications. So discontinuing the anti-seizure meds is it's a controversial issue. Clearly, it should be done under close medical supervision. But if a person does have these various factors, that person may be a candidate to try to discontinue the anti-seizure meds. So let's summarize our major concerns about these medications. First, you may be working with a patient that has a seizure disorder unrelated to why we're seeing the patient in physical therapy. So simply be aware of any patient that's taking anti-seizure meds. It's certainly true for patients in a neurological setting, but we could be working with a patient in an orthopedic setting or a patient with a sports-related injury like an ACL tear. And this person simply has a seizure disorder. So make sure the patient is being adherent to their medications. And likewise, be aware that a seizure could occur as you're working with this patient in any kind of a setting, neurological or otherwise, and be ready. Be ready with normal precautions if a person does have a seizure. Secondly, we're in a really good position to help document seizure activity and help determine if the medications are effective. This is especially true in children, where if you're working with a child, on a regular basis, you may notice a subtle but regular increase in the number of seizures. Now, of course, some of these seizures are rather subtle, and unless you actually have your hands on the child and notice a change in tone or a change in affect or the fluttering of the eyes, we may simply miss that seizure. So we're in a really good position to pick up on when seizure activity starts to increase. Some of these children will literally outgrow their medications. The medications were effective 6 months ago, but the child is starting to go through a growth spurt and literally needs more medication. So once again, you may see this as a gradual but subtle increase in seizure activity. We can go the opposite extreme. Perhaps it's an adult now who has a very high dose of the anti-seizure drug, and the seizures are very well controlled, but the patient is so sedated, or other problems like lack of coordination are really limiting the patient's progress in rehabilitation. So once again, we're trying to find the middle ground. What's the dose that helps control the seizure without causing excessive side effects or even harmful side effects? So that ends our discussion of seizure drugs. Very important, very valuable medications, and we're hopefully going to see our patients find the right combination or the right dose or both so that they can progress whenever we're working with them.